Mohan sir and Govil sir's videos.
You start.
Mohan sir. Sir.
You start, sir.
Okay, sir. Good evening, all. Welcome to the ISCCM VIzag live webinar. I am Dr. J. John David, Chairman, ISCCM VIzag branch. Today, all of you welcome for this today wonderful webinar. And we have very good speaker, Dr. Mohan S. Maharaj. And we have a prestige to have our President of Indian Society of Critical Care Medicine, Dr. Deepak Govil, sir. Thank you very much, sir, for accepting our invitation and to be here as a moderator and expert panelist. I would like to introduce Dr. Deepak Govil, sir. Dr. Deepak Govil, sir, he did MBBS in LLRM Medical College, and he did anesthesiology, MD in LLRM Medical College, Meerut, and he did European Diploma in Critical Care, Intensive Care Medicine, EDIC, in 2009. And Dr. Deepak Govil, sir, is the Director of Medanta Critical Care Services, and he has been working as a intensivist, critical care specialist more than 25 years. And he is the teacher and examiner for FNB, DNB, IDCCM and FICCM. He has contributed to the several chapters and he is the author of ICU guidelines and co-author for the papers of national and international journals. He has actively participated in several international trials and studies. Dr. Govil sir has served as a Vice President of the Indian Society of Critical Care Medicine and Vice Chancellor of Indian College of Critical Care Medicine. He is the Chairman of Guidelines Committee, besides being as a member of the Constitution Amendment Committee of ISCCM. He has been organizing numerous critical care symposiums in the past 2 decades. Dr. Govil has been awarded fellowship by American College of Critical Care Medicine and Indian College of Critical Care Medicine. And he is the director of WinFocus ITO Delhi. Presently, he is working as a director of critical care services, Medanta, the Medicity, Gurugram, and he is the president of Indian Society of Critical Care Medicine National. Thank you very much, sir, for accepting being a moderator and today's expert panelist. Now I request Dr. Achyut to introduce the speaker. Thank you, sir. Thank you very much.
Thank you very much for illustrious introduction. It's my privilege to become moderator today. Dr. Mohan Maharaj is presenting and you all are there. So it is my privilege and I'm feeling honored to be here. Good evening again. Thank you very much.
Thank you, sir. Thank you so much.
Good evening, sir. Good evening, all the gathering. Good evening, Dr. David, my chairman of ISCCM VIzag. And good evening, Dr. Mohan S. Maharaj, today's speaker. And I thank wholeheartedly Dr. Deepak Govil for accommodating our request in his busy schedule and being the moderator and expert panelist for this event. Thank you very much, sir. As a formality, I just need to tell that last month we conducted the minutes of the last meeting. We conducted ISCCM academic meeting last month on the 12th of February. And the topic was fungal infections in immunocompromised and transplant patients. And it was attended by 60 candidates online. And that was a big success. Thank you. And to introduce the speaker, today's speaker, actually Dr. Mohan Maharaj doesn't need much of introduction. He's very familiar and famous in this region. If not whole of India, at least South India, he is well connected with everyone. Whoever is qualified, MD, anesthesia. Sir?
No, sorry to interrupt. He is well famous in all over India. Everybody knows in North India also.
Yes,
Right.
sir. Yes, sir.
Thank you. It's an honor for all of the VIzag ISCCM branch, in fact, to have him here. Thank you, sir. So, Dr. Mohan Maharaj is presently working as Director of Intensive Care at Care Hospitals, Visakhapatnam. Previously, he was Head of the Department and Medical Director of Care Hospitals, Visakhapatnam. And his academic front, he did MBBS from KMC Manipal, and then MD from Shivaji University, Maharashtra. And then he did PDCC in cardiac and neuro anesthesia from NIMS, Hyderabad. And he spent a good number of his formative years under the guidance of Dr. Manimala Rao at Nizam's Institute of Medicine, Hyderabad. And then he moved to Hyderabad, VIzag, as a hospital, and since then he is associated with care hospitals in various positions. And recently he was elected as EC member of South Zone ISCCM branch, ISCCM chapter, and he is contributing administrative aspects also in the ISCCM now. And he in the COVID pandemic, he treated close to 2,000 patients successfully without any fear. And towards the later part of the pandemic, the first wave of the pandemic, he got affected by COVID, and thankfully he came out without major problems. And now he is going to share us his experiences with Hfno or Hfnc in non-COVID situations. We had extensive discussion many times on the role of Hfnc in COVID patients. Now we can extrapolate the experience into non-COVID situations. And let's have the information from Dr. Mohan S. Maharaj. Thank you, sir, and over to you.
Thank you, sir. Deepak Govil, sir, shall I start?
Yes, please.
Yeah. Thank you very much for the introduction, Dr. Achyut, and thanks to Dr. David, and thanks for the opportunity given to me to share Hfnc requirements in non-COVID. And now, really speaking, more than 2008 onwards, we know how to use Hfnc as intensivists as well as anesthesiologists. We have used Hfnc in multiple times and multiple cases, but more awareness has come in the time of COVID. And with that, what I can see is that want to allow this. The use of Hfnc in non-COVID has to be now more important, but with the second wave again,
some people, sir, Vijita, Miss Vijita, some
Yes,
people messaged me saying that they're not able to log in.
So if any network issue is there, then they will have the same issue.
Right.
They can just
can they directly see the program on YouTube or Facebook?
Yes, yes. The links I have just shared with you, no, in the
Right.
WhatsApp.
Yeah.
You
Okay.
can just forward the links.
Yeah.
Yeah.
Right. Yeah. Okay. Sir, please go on, sir. Sorry for the interruption.
no problem, sir. Is it visible, sir?
Yes, it
Yes,
is.
sir.
Yes, sir.
Yeah. Thank you. And it's particularly there's nothing new about non-COVID because we are using this for more than a decade, and more awareness has come in the time of COVID because of this beneficial all the effects. But at the same time, how better once we purchase most of the nursing homes, most of our hospitals, when we purchase more than 10 to 20, how to utilize them properly and how to make use that our efforts and the cost is going to be useful. So we can say that Hfno nasal oxygen is one of the best mode of, even though it is not superior, but definitely it is not inferior to the NIV and definitely superior to the conventional oxygen therapy. So because of it has for introduction sake of thing, I would like to say that it has a flow meter where you can adjust from 0 to 70 liters, minimum of at least you can put 10 liters. And the blender where it can mix with the oxygen, air, and you can with the flow of it. And having a humidifier where you can maintain the temperature between 31, 34, and 37 degrees. And also heated circuit, which is can avoid evaporation reduction. And the nasal cannula, which is having 3 types like adult, small, big, and pediatrics. And we used to use previously also. This is how it is. And the continuity of humidification is more important as a physiology, and we will go in further slides. So the physiological effects of Hfno nasal cannula oxygen is it washouts, dead space, and I'm sure most of you in between I'm interpreting because interrupting. Yesterday, if somebody has been understood the class and it may be boring for them, but still it is like again important and useful. And how it is going to reduce the nasopharyngeal resistance and the humidification of mucociliary clearance because more physiological, and regulation of inspiratory oxygen, how you can really do much better compared to the conventional. And the positive expiratory pressure may not be high, but at least up to the 5 to maximum of PEEP. And alveolar recruitment may be up, particularly post-operative patients. If you see the pharyngeal dead space washout, normally with high flow, it clears the carbon dioxide and replaces with O2 abundant gas of this. And they have studied, and it is published in 2015 itself, that when you give 30 liters in the control patients and how it has been removed, which is useful for us for in apneic ventilation. And a relation with the amount of flow is actually not really determined with the COT, but here when you give depends on the size and anatomical shape of the patients that actually improves and wash out the carbon dioxide. And this is definitely useful, particularly in the patients of intubation, whether in ICU or particularly in the process of smaller procedure cases. And they have been studied, experimental cases has been studied and seen how much differentiating. But when you take it 40 to 60 liters, the difference definitely there is a 0 liters to 60 liters has been proven. It is going to wash out clearly. And the humidification and mucociliary clearance, we know that as a physiology, the dry gas they have studied particularly in the pigs and the dogs, and which is making the cost and having the difficulty and making cause even ARDS because it doesn't have a humidification. So with this dry air is going to be dangerous, can cause bronchospasm. And not only that, even though we cannot really calculate work of breathing, we can really see the energy cost is been reduced. So that is warmed up upper airway is beneficial. And it is a reservoir for us, and impaction of secretions can occur. So that's why Hfnc is definitely beneficial because of this humidification and proper humidification, how we actually monitor and do clearly with the screening. And it also increases the mucociliary secretions. Generally, maximum humidification occurs at 40 liters and 60 liters. The determination is not exactly correct, but definitely it's useful. And even with the full saturation, higher flows is questionable because that if you see at other conventional oxygen therapy, the entrapment is there, but whereas here you can adjust it. And the additional heated humidifier can be added. And with better humidification, definitely mucociliary function is improved. Particularly ventilator, anyway, it's going to stop. In anesthesia, it is going to stop, but here it can still continue. Depending on the regulation of inspiratory oxygen, the desired FiO2 can be provided more reliably compared to the flow, because when you have seen that patients of having a 10 liters or 15 liters of flow you are giving, even the minute ventilation when the patient is on sepsis or having a high metabolic rate, the requirement of minute ventilation is going to be high. At that time, even if you give 50 liters per minute, the requirement is high. Because of that, entrapment occurs, FiO2 cannot be clear. So with this, you can really maintain the FiO2 as you desired. And some patients where you don't require much of FiO2, still is useful. You can control it to reduce, whereas oxygen flow cannot reduce the oxygen because the flow is very high. And high flow nasal cannula generates positive pharyngeal pressure, which produces certain amount of pulmonary expanding pressure and promotes alveolar recruitment. And particularly, it can prevent the atelectasis. That's what we can really say as per the studies. If you look at it, we all know that NIV means there is a closure of both the nose and mouth. But with Hfnc, you cannot close the mouth. So, but at the same time, the mouth closed and mouth open. Mouth closed, the PEEP is okay up to 4, whereas 0.6 to 1.7 you can go even with the mouth open. Whereas mouth closed, you can go up to 2.2 to 4.8. So that was the studies has been proven in this, and the different number of randomized control trials as well. If you look at that electrical tomography, impedance tomography, it has been shown, and the alveolar requirement, how it has been, you can see that here that the end of expiration, how it is there, and whereas at the full peak of expiration, how much it is being given. So this is how we can say that the end expiratory lung inflation per percentage of the maximum is going to be beneficial in the studies. So you can see this, how it is beneficial. And but at the same time, you can have to look one point here that the BMI is more than 30, that's actually beneficial. We will show you in the further. We all very well know, understood that the patient comfort and the compliance and the claustrophobia of the NIV and the more effective care, they can spit on, they can talk, and they can eat, and the comfort is much better. It has proven 48% better than the NIV, and beyond any doubt about it. Normally, how we actually go ahead about it, the benefits of this, when you are giving all these benefits compared to the physiology. You are giving heated humidified of inhaled oxygen, and you're washing out the upper airways, and you're actually increasing the high nasal inspiratory flow, and there's a minimal positive airway pressure. At the same time, decrease entrainment of ambient air. These are all what the benefits of HFNO. When you're having these benefits of HFNO, the flow chart is like that. Because of washout, decrease of dead space, and because of humidification, increase of secretion clearance, and decrease of bronchoconstriction. So this is how the flow chart. To have a less time on this, we all can go through that, and its inspired oxygen is increased. And when you look at this, if you see clearly, the flow chart has been clearly mentioned that how the dynamic compliance and as well as the decreased respiratory rate. Normally, it is very difficult to see inspirate effort is been reduced. That means indirectly work of breathing is actually beneficial. So we all know that silly, willy, and because of the particularly COVID patients, self-induced lung injury or ventilated lung injury, when you're having a ventilator or NIV. So how this is going to be reduced, the stress and strain and opening and closing and stress raises, these are going to be actually beneficial, and the power is being reduced. So the cost of that, instead of work of breathing, the cost of energy being beneficial. So this is how totally the improved clinical outcomes. So we can really not only hypothesize, it's been studied from 2014, 2011 onwards, and various studies are beneficial and showed the benefit out of it. So we can call these indications very clearly the acute hypoxemic respiratory failure. Previously, we used to think that non-hypercapnic, but no more, it's 100% guaranteed non-hypercapnic because it is not inferior to NIV, and acute exacerbation of COPD, and particularly post-extubation of more than BMI 30 or post-cardiac surgery beneficials, and to prevent the reintubations and the complications, and particularly procedures like bronchoscopy in ICU, and during intubation either in ICU or particularly for procedures and post-surgical patients. And you have to really think about this is one of the important factor of palliative care, because how easy and acceptance by the patients, because they can talk, they can give the directive orders by themselves to the patients and the family, particularly in Indian scenarios. So acute hypoxic respiratory failure, we need to think that, but keep it in mind that severe ARDS, you are not supposed to start with HFNO, but mild to moderate, yes, it is beneficial. You can start, and can be used first line support in place of NIV. And patients requiring oxygen support more than 10 liters per minute with the tachypnea more than 15 minutes can be started on HFNO directly, because that's what we need to look at, 10 to 15 liters up to 15 minutes. And look at that high flow oxygen through nasal cannula in acute hypoxemic respiratory failure. It is a 2015 published. I think every one of you know about Florali study and how important it is. What is the benefit out of it? There were three actually having randomization of the patients has been done. And what happened was in France, almost 23 ICs has been included. Actually, 27,800 people were included. Out of that, there were so many patients has to come because of the inclusion exclusion criteria. There were only 300 people have been left with out of 422. In that, there were 96 patients, 110 patients, 106 patients were included in each different study. So in that, we performed an open label multi-center trial, and which was almost looking at the FiO to PiO2 ratio of having oxygen less than 300 mmHg. And they have been selected and looked into the primary outcomes, some secondary outcomes of the primary outcome of 28 days reintubation rate, and the secondary outcome of 90 days mortality or free ventilator days. These are things they looked into and said that how far these three are beneficial. Definitely, it has been shown that since the 0 day to 28 day, the high flow oxygen was much better compared to the non-invasive ventilation. The number of cases were requirement of reintubation, and the overall population, if you look at that, even though average of 100, there is a small caveat at the end saying that the power of study because of 300 patients is not so great, but at the same time, it was gold standard that HFNO can be started and beneficial. And looking at that from outcome of the patients, when you look at the survival, probability of survival 90 day, definitely HFNO was much better, because you look at the type of recruitment, most of the patients were pneumonia patients in this study, because unlike other, we can say, hot ear study where they have not, it is not a pneumonia cases, it was a particularly where we have excluded from here like a pulmonary edema or COPD patients. So the another benefit I can say about Yang and Leong, high flow nasal cannula oxygen versus non-invasive ventilation adult respiratory acute respiratory failure, a systematic review of randomized control trials. It's a review article which has been shown and say benefit that if you have two varieties, you have a less than 300 PO to FO ratio, less than 200. When you look at that, the more severe hypoxemia patient, less than 200, still those patients, when you start early HFNC versus HFNV plus NIV. So there was a group saying that in acute respiratory failure, the benefit has been shown. Primary outcomes included intubation or re-intubation rates has been shown. Secondary were ICU mortality and morbidities. So this is one study which has been published in 2018 and showed a benefit out of it. And despite these differences, there is a viable option in patients with less severe hypoxemic respiratory failure from pneumonia and AIDs, as well as the patients with risk of post-extubation respiratory failure. If you see hypercapnic respiratory failure, because the one thing everybody have a debate and question saying that how it's going to be beneficial, but no great evidence regarding the use of type 2 respiratory failure. We all know about it, but at the same time, we should not go ahead of NIV for all these cases, because to see whether the PCO is 45 or more, and is it going to be more than is a post-extubation or before extubation or having already treatment. Last time there was a study looking at the cases like post-pulmonary effects, like Ariscot trial. When you look at the score, they have a post-pulmonary complications, either post-operative or particularly in ICU case. When you have a problem, how do you look at that? Studies shown to have a positive effect on long-term humidification, because it prevents the atelectasis and avoids the re-intubation compared to the NIV, because the recruitment of the patients were like that. We all know about global initiative for the chronic obstructive lung disease, and it has been said that the HFNO involves nasal delivery of heated humidified oxygen, and it is a systematic RCT. Patients with acute hypoxemia respiratory suggest high flow oxygen tends to reduce the intubation rate, but did not meet statistical significance here in this therapy with NIV. But definitely we still can use about these patients, because looking at the PCO2 levels. And if you see the high flow cannula respiratory failure systematic review meta-analysis, we really have to look at this paper. It has given elaborated very clearly about meta-analysis. They looked into studies of actually 612 studies were reviewed as per the, you can see the Ottawa methodology of statistical significance, whether you can really take the study proven beneficial or not. And in that, because of the, again, having a same type of studies, same type of patients, they removed. Finally, they come with only the 8 of RCTs and 2 of cohort studies. In that, almost 6 of studies were beneficial, and 2 cohort and 2 RCT patients have a more beneficial about the NIV or equivalent. This is how they have studied. If you look at the most of the studies in the review analysis, not only that, it's almost all the indications have been reviewed properly and said that the Hfnc is non-inferior to NIV, and particularly in some particular set of patients, it's more useful. And they also looked at a ROX index, when you look at the respiratory rate and FiO to PO2 ratio, how it's going to be beneficial. If it is approximately, they say that it's around 4.8 is beneficial, and never continue put a Hfnc more than few hours. You assess the patient just like a ventilator after 1 hour, and look at the Ariscot score or this score after 12 hours, and think whether you're beneficial or not beneficial. If the Hfnc is not using beneficial to the patient 48 hours, never continue it, again go for, because you need to do this systematic methodology. Coming to the post-extubation HFNO, and extubation failure in ICU in acute respiratory failure around average of 20%, and it can go up to, depends on some studies, 47%. So, but here the type of cases recruitment when you are doing, as I mentioned previous slides, also one study saying that if the surgery is a major surgery, it is a thoracic surgery or abdominal surgery, or like for those kind of patients, you're not supposed to put a particularly abdominal surgery NIV, because it has a gas insufflation. These are better with HFNO, and depends on the surgery, and BMI is less than 30. So the different risk factors were found, including the age, duration of the illness, and comorbidities of the patients. So particularly we need to have a selection of which patients are going to be beneficial. Definitely it is useful, and particularly whether you use this as a primary modality in high risk patients, then that's okay. But at the same time, you look at the patients requiring NIV, that means the outcome is going to be a little bit difficult, because the risk is high. The Apache score is either more than 12 or it's more than 24. So if it is more than 12, definitely we can still consider about HFNC, but if it's going more than 24, requiring a pulmonary edema, going into the NIV, you still can go with the NIV. Otherwise, start with HFNC. HFNC can now being used as an equal alternative NIV to prevent extubation failure, because if you see most of the ICU patients, we are very much worried about the average length of stay and cost effectiveness and reduction of the ICU stay and reduction of the ventilators. So on all the complications, reduction will be there, cost effectiveness will be there. And those patients, when you look at it, along with Hfno, they have studied together with the NIV and Hfno and looked into that how beneficial it is there, and whether you have the score of what is the score of FIO to PO ratio less than 300. Those kind of patients, they have been tried with Hfno rather than less than 200. And it's not that they want to re-intubate early, but at the same time, look at it which cases to be there. They have given around 5 to 6 points. And effect of post-extubation high-flow nasal cannula versus non-invasive ventilation in re-intubation of post-extubation respiratory failure in high-risk infects. This is the randomized clinical trial which is actually done in 2016 itself and showed that it is beneficial. And look at it, when they look at a primary outcome or secondary outcome, there's a all-cause re-intubation was almost to near to that. They say it's not inferior to it. I don't say it is superior, but definitely not inferior. And the respiratory failure, when you look at it, in mechanical ventilation, there was 125 patients, whereas in high-flow oxygen is only 78. So it's only 26.9%. This is one of the very positive points we should look at it, how the post-extubation respiratory failure, and look at the adverse events also. Because of the problems or the complications and the difficulty in adverse events, the NIV was having almost Hfno was 0. I mean, it's really they'll be supporting this study very well, but at the same time, keep it in mind. And but there's no much difference about whether mortality and multi-organ failure. And definitely, as physiologically, it is more useful. The ventilator-associated pneumonia is less in Hfno patients. So, in hypoxia, greater hypoxemia in NIV group could be explained by the lower actual time under effective preventive NIV due to withdrawal for discomfort. So that's one thing what they looked at and said that given the explanation. And but the 50 liters per minute of flow tolerated by the high-risk patients clearly higher than the 30 liters per minute flow tolerated because they were requiring a high flow of oxygen. The reinforcing the idea that flow told the marker of this one. Look at the conclusions. We can only say that I can tell you in this as a team efforts. I don't say we should only go with NIV, but hand in hand with NIV and Hfno is really much beneficial. You can prevent the reintubation and the complications. And bronchoscopy, most of us are intensivists are doing a bronchoscopy nowadays, and previously there used to be 2 people and difficulty and somebody is helping on airway, and this is actually here we can really say that they have had hypoxic apneic for 17 minutes, not less than 90% of oxygen has been there for this. This is an important point to note, which is useful because in bronchoscopy we are sharing the same airway, and you cannot really put NIV in between. Even at the time, so oxygen insufflation previously we used to do, but after getting Hfno mission in bronchoscopy we can do very easily, and because that is a task for us to do, so we have to reach the all and look at whether you do ball or you look at the condition of the patients. So it has given a sufficient time for you. So it's much useful for us. So HFLC is a modality that can be used safely during bronchoscopy. Not only here, the study was that they have studied almost 50 patients and 1 in 30 patients saying that high-risk hypoxic patients, this was much useful because not only for the patients of routine bronchoscopy when you do, in particularly for hypoxic patients of requiring an ICU, the HFNC was much useful. So this high-flow nasal interface improves the oxygenation in patients undergoing bronchoscopy. This was a study and said whether you have 60 liters or 40 liters, SpO2 between the 60 liter and only detected difference. Otherwise, it was a much better study of this. It's definitely better than the venturi mask. And we know that in particularly whether you call it as a COVID time or non-COVID time in emergency, what happened was in emergency when they looked at the difference was not much, and NIV was much better than Hfno they've studied. But they look at a post hoc analysis and the type of cases which they recruited, it was different. So at the time of intubation, when you put NIV, you have to remove it. And at the same time, if you are previously, we used to do 15 liters of nasal prongs and continue to do intubation because at the time of hypoxia, apneic time, there was a much better time for you. Like you're not only removing the carbon dioxide, at the same time, like denaturization we do in the operation theater, this is also beneficial, having a prevention of the problem hypoxia. It has been only up to 80% it is reached because it hypoxic patient at the time of emergency intubation, like you're giving a breathing of minute ventilation with 100% oxygen. This is much better. Instead, we normally do. NIV, definitely it is not superior at the time of intubation. So before and after study, when they looked at it was beneficial, they did it for 100 patients, and they look into, definitely there's no much debate on it when there is a face mask and HFNC. We all know that HFNC is much better than face mask, whether we call it as a mucociliary secretions, whether we call it as a humidification, whether we call it as a oxygenation, anything, because there's no continuity or clarification of this. So there was almost 120 patients of study of 2015 published in intensive care medicine, whereas the other one was in randomized control trial, which was published in 2016, was 150 patients. These two has been again showed and benefited that this HFnO is much beneficial. And particularly post-surgical patients, what they have studied was more than the thoracic and abdominal surgery, even a cardiac surgery patients. You know what happens in post-cardiac surgery, even though they're cardiac patients, we really have to have a better acceptance of the patients is HFnO rather than the NIV. Because we previously, with the fast track of our anesthesia and extubation early, the difficulty and prevention of, because they have ICDs, they have a lot of some doing off pump cases nowadays. So the best thing is that having HFnO, because that can prevent the athlexasis, and also having a good secretions bringing out and easy acceptance. So the standard oxygen therapy may not be effective in correcting hypoxemia, particularly in these patients that have been studied and proven. And when you look at it, CPAP versus NIV, definitely we will say that NIV, but here there is an alternative for HFnO where is better therapeutic advantage over other different surgeries are there. So there is a prospective trial of Hfno nasal cannula oxygen surgical patients has been, different people have been studied. They have been shared that how the comparison versus between the conventional oxygen therapy and the HFnc 35 to 50 liters has been studied, and the outcomes have been differentially said, how beneficial about athlexasis, how it is beneficial about the requiring of escalation of respiratory support. Because if you see one study when they anything, sir. So this is what different studies has beneficial, particularly if a lung surgery, because in lung surgery there is much beneficial of HFnc compared to the and also it prevented reintubations. And coming to the palliative care, how difficult it is end of life care, palliative care. We all know as intensivists, how do we used to think about the indication of no intubation instead of avoiding and having a robust mechanism and having a stress for the entire system. We thought we go for a NIV, but now we have an alternative of HFnO, and where we can still, patient's comfortability is there. They looked into almost more than 26 to 96 years age, how beneficial it is. It is proved capable of providing similar symptom relief, and anyway, even for the do not intubate patients, it is more useful, and it can be continuously delivered as we require, and still can be effective symptom of palliation can be done. So it is been studied in 50 patients and showed how much beneficial it is. And not only that, end stage pulmonary fibrosis, only 18% of patients progress to NIV, because while 82% were managed with HFnO alone. So these are all the indications of HFnO nowadays. And another, particularly, I can say that the Thrive study, I'm sure Dr. Achit will have a more explanation about, and seeing that how this high flow humidified in ventilator exchange of the insufflation is useful, but particularly for hypoxic or apneic patients. It's almost how beneficial it is for intubation. In anesthesia, it has been studied and clearly mentioned that how useful it is. So with this time, I would like to thank the people for giving me opportunity and hand over to the chairpersons and to Dr. Deepak sir.
Thank you, Dr. Mohan. It was an excellent talk, and you covered almost all the aspect of HFnOV and its indications.
Sir.
So I request chairperson to stay.
I request Dr. Deepak Govil sir to explain his experience about HFnO and from his side. Thank you, sir.
Sir, as you said, we also acquired HFnO a few years back, and we were using it exhaustively in all the conditions. The only situation where I find little less useful is the type 2 respiratory failure with the CO2 retention. But believe me, the patients who are intolerant to NIV, they are very much tolerant to HNFOV. So there are very few, if I say there are around 30 to 40% patients who are intolerant to NIV. With HFNOV, it is hardly maybe 5% or less than 5% which are intolerant. So the tolerance is a very good thing. The better tolerance is better compliance with HFNOV and better results are there. So may I request chairpersons to start some question answer. If there is any question answer or any discussion, then we move on and we'll discuss further.
Yeah, sir, can you please share us your experience for using HFNO in the operation theater setting?
You are asking me, Dr. Achyut?
Yes, probably.
I'm not a right person because I left anesthesia many years back and I have not been.
Yeah,
so
right. So
probably Dr. Mohan Maharaj can give you better answer.
Explain. Sir, can you please explain us the role of HFNO?
Achyut, I think that's the reason I mentioned at the last slide about the Thrive study. Because you have been presented. That's why I thought you can talk about Thrive.
That was some time back, sir. But I mean, I haven't used HFNC in difficult intubations. But as an extrapolation, we can definitely use HFNC to buy time in case of difficult intubations, and the same principle can be used in the ICUs as well. And
our experience is particularly in cardiac surgery patients, Achyut, because we use HFNC patients for weaning of the patients post, because as I said, in post extubation, and instead of going to NIV combination as a team, it works with HFNO is much better. Whether you remove the HFNO or whether you remove the NIV and put the HFNO better rather than the conventional oxygen therapy, because that gives a lot of comfort as well as whatever, because all the 5 to 6 benefits, whatever we talked about as secretions, mucociliary function or talking or nasal bridge complication of NIV, all these things are prevented and it is useful. And particularly in the procedures, intubation and you give ambu bag and ventilation, particularly in OT, and rather than that, in HFNO is almost same effect. There's no much difference about it.
Right, sir.
And although I don't have got any experience, but another place where HFNOV can be used, HFNC can be used in operation theater is the regional anesthesia. So in many patients where you are giving regional anesthesia and they are having some respiratory compromise, majority of them, like we prefer blocks to and other regional anesthesia to those patients who are having advanced COPD and other ailments where they are supposedly unfit for GA. So in that subset of the patient, one can use HFNC very well to avoid the complications.
This is Dr. Company fellows.
So Dr. Padmaja has asked one question, that isn't the cost of consumables a barrier for short-term indications like apneic oxygenation, pre-oxygenation? I agree with you that the cost is maybe a little barrier, but try to I'll tell you what we do. Except the nasal cannula, the tubing, the circuit, the humidifier chamber, we get them autoclave done, and we use in 3 to 4 patients. So the cost of those things can be distributed because the air is not going back to the expired air is not going back to system. So it can be reused easily with autoclave. So we do it autoclave and we use in 3 to 4 patients, maybe 5 patients. So the cost of that consumable is gone down. But of course, the cost of nasal cannula one has to bear.
I think with the permission of... Yes, sir. Tell me, sir.
Please. There are other questions also. So, if you would like to tell...
not the answer, sir. Not the answer. What I want is that Padmaja madam is having in her mind. I just want to ask her. Because she's having a NIMS HOD, she has a lot of experience.
So, Dr. Kasper is asking, what is the flow required and what is the effect of Venturi effect on HFNOV? So, Dr. Maharaj, can you answer this,
sir,
or any other?
Venturi effect, we have Venturi mass, there is a difference. But whereas HFNO, you can adjust both the things because you can adjust the flow, you can adjust the oxygen percentage differently. You don't have to, there's no blender, even the blender is there, there's only adjust. So that way, it is much beneficial, sir.
Madam Padmaja again asking about the use of HNFOV in COVID era. So probably she is asking about the reuse of the circuit. So that is what I am coming to, ma'am. In COVID also, believe me, during the pandemic, we were really having short supply of the consumables. And what we did at our place, we reused all the circuits except the nasal cannula after the autoclaving, even in the COVID era, because there was a time when company people almost raised their hands that they cannot supply. Like in our place, almost 8 to 10 patients were on HFNOV, and you can appreciate the daily consumption of the circuits were very high because many of them were using HFNC for a day, 2 day, 5 days, 6 days. So there was lot of like movement in there. Fast turnover was there. So at that particular time, we started reusing it, and that practice is still going on.
Sir, my question to both of you: shall we use normal saline as a liquid because it is producing a lot of salt and blocking that chamber?
No, sir. We have a deionized water separately with the bottle, which actually comes there and we can connect. That is better. That should be used, sir. That's a good question. Anyway, you know it, but you asked it for the sake of everybody. We understand.
RO water would be the cheaper option.
RO water or distilled water?
RO gives distilled water.
Our hospital prepared distilled water or company prepared distilled water?
The RO water from the RO plant would be cheaper option if at all you have to spend on it. Sir, my question to both of you or one of you, how do you escalate the support on HFNC and how do you wean the patient from HFNC? For the benefit of the wider audience, please.
Yes, sir. Deepak, sir.
Yeah, so escalation is gradually you increase the flow and increase the oxygen concentration. Again, the catch point here is the failure. Same thing which happens with the NIV. If we are on 100%, almost 100% oxygen with full flows, at that point of time, if we feel that HFNC is now failing, then for intubation, patients give very little time because he or she is already desaturating. So we can't pre-oxygenate that patient further. So that is the inherent risk. Like it happens with the NIV as well. If we delay intubation too much with the NIV, many times the intubation becomes very tricky because patient doesn't give that much of time. So what I would suggest that don't wait for final failure. Just preempt the failure, and before the patient goes on 100% or that time, plan for intubation, safe intubation. You may intubate little later, but planning should be there. That is one thing. At the time of failure, what I suggest is if there are two people, one experienced person is there for intubation, it is much better because at that point of time, patient will not give multiple chance of intubation. Majority of time, you will have to give a single go. As far as weaning is concerned, so what I do, we gradually start weaning the oxygenation and side by side we decrease the flow as well. Once the flow is reached to 20-30 liters and FiO2 is reached to maybe 25%, then we wean it out and we put the nasal cannula or face mask.
Right. Sir, do you bridge NIV, use bridging NIV between HFNO and the invasive ventilation? Or straight away, do you go to invasive ventilation straight away from HFNO?
It depends on the patient to patient. Like in COVID era, we are bridging because in COVID era, we want to little bit delay the intubation. In otherwise routine practice, majority of the patients, in non-COVID patients, what my experience is, majority of the patients who are not doing well on the HFNC are not even doing well with the NIV. So
Right.
Majority of them directly get intubated. Of course, in few patients where we feel that high PEEP may be beneficial, then we move to NIV from HFNC. Right,
sir. Sir, one more question. Were there any fears about the pollution of the environment with the infective material, especially in COVID patients, when we are using high flows on HFNO? Any idea on this, sir?
Is all controversial. If you remember, Dr. Achyut, in early days of COVID, all around the world, everybody was scared to use HFNC, and all the experts were saying, "Don't use it; will spread." Blah blah blah. Gradually, whole world has started using HFNC, and we feel that mortality is better with the use of HFNC. The mortality is less with the use of HFNC. So, I don't know.
Right, sir.
No, definitely found, sir. Particularly, immediately we took almost 20 Hfno missions when we started COVID, and there was a much acceptance and outcomes are much better because, as you said, even though particularly in ARDS patients of sepsis patients, there the Willy Silly is very high, but whereas COVID patients, that problem was not much because of the pathophysiology of this disease itself. So that no, like how you call it as a unscientifically you call it as a steam inhalation. The same way, the correct way of humidification and temperature maintenance, as well as the flow adjustment and acceptance, everything is very good. And as one small thing, as Padmaja madam is asking about RAS score useful, definitely, ma'am, I'm sure. But only thing is the number is not exactly great. That is not given evidence. 4.8 even they say after 12 hours. As Deepak Govils are telling that it's like NIV. You have to look at first 1 hour whether it's going to be improved, whether he's having any other systemic problem or having abdominal breathing is there or not there, and the patient is not only just reduction of respiratory rate. You look at other aspects working or pH and acidosis is there, and reassess at the RAS score of around 12 hours and looking at how beneficial, then not to continue more than 40 hours is not improving. And unless there is an indication required for intubation, definitely it not a decision making, but definitely useful, madam. Thank you.
One more question from one of the audience is it useful in the pediatric and neonatal population? I don't have much experience in pediatrics and neonatal.
I'll tell you, particularly, we have been using indirectly most of the pediatric patients post-extubation, post-cardiac surgery. All congenital patients, normally we use this. And that was the best method of it because the requirement of PEEP, the requirement of physiological method is much less in pediatric and neonatal patients. So they are more useful actually. They're more useful for them.
Right. So
even at our center, although, sorry to interrupt, although I'm not dealing with neonates, but I have seen in my center as well that the liver transplant patients, the pediatric team is using extensively HFNC. And even in the neonates as well, like in the smaller kids also, because suddenly like they are on ventilator for 2-3 days and suddenly we extubate them. So many times the reintubation rate was there, or everybody was jittery in that intervening period 2-3 hours. So now they have made it a point that they wean on the HFNC and gradually by next day they wean to the oxygen therapy.
Right.
Sir, can you differentiate the bubble CPAP and HFNC in pediatric population?
Actually, we have the difference is David, HFNO. This all 4 things are there, but the neonatal normally we are not using as an HFNO. Bubble CPAP we are using more. But at the same time, this is useful nowadays because of this availability of these gadgets easily. So this is more easy of using it.
And majority of the patients are not majority. Some patients have developed pneumothorax or pneumomediastinum with high flows of HFNO, like more than 60 flows. What is your experience on that?
No, we don't use more than 60 flows, but neonatal we don't have experience of which HFNO of 60 liters.
Not neonatal, sir. In adult patients, flow of 60, not more than that, at least 60 flows. Some patients develop pneumothorax or pneumomediastinum.
See, pneumomediastinum is a case where we're having a high flow, giving oxygen, even ventilator patients get pneumomediastinum and severe ARDS is there. That's where the hypoxia is demonstrating. It is not maybe because of this, because I understand that pneumomediastinum is one of the, you can see that is a high risk and it's you can, as the continuously of oxygenation improving, that will come down. And previously, if you remember, we worked together 10 years back, we used to put both side ICDs and for the pneumomediastinum. So by our pulmonologist Prem Kumar sir and also telling, and that's how we actually treated. But afterwards we have stopped it. We know that once the ARDS improves, that also improves.
Can I share my experience in COVID? What we observed is much more incidence of pneumomediastinum and pneumothorax with the use of NIV rather than HFNOV. I can't say that it is a zero incidence, but the number, if I compare with HFNC and the NIV, the rate of pneumomediastinum was much high in the NIV group, although there is no randomized data or any data, but I'm just telling you with my experience. So if you want, you can take it. Otherwise,
Sir, my extension.
One more question in premature neonates.
Yeah.
There is another question in premature neonates. Can it cause oxygen toxicity? I don't think so. It can cause oxygen toxicity because in Hfnc, the beauty is we are giving calculated oxygen. So there is no unregulated oxygen is going on. And one can very well bring it down to room air, almost 21%. So there should not be any chances of oxygen toxicity if we are calibrating the oxygen requirement of the patient and giving appropriately. Yes, Dr. Achyut, please.
Sir, my extension question actually with pneumomediastinum or pneumothorax, and we worry really about the tension pneumothorax developing with the invasive ventilation unless we put intercostal drain tubes. With Hfno, can we use Hfno in pneumothorax patients without putting intercostal drains?
Boss, it depends on the extent of pneumothorax and pneumomediastinum. If it is too big, then you have to don't take chance. But if it is a smaller pneumothorax, then one can do a close monitoring.
Right. So we can wait on Hfno even if there is pneumothorax if it is small for some time and keep monitoring the patient. Right. But unfortunately, we don't get the airway pressures in Hfno like we get in invasive ventilation. That's the only negative side of it on waiting.
If you look at Achyut, invasive ventilation, we can still have a whether PEEP or humidification, but for NIV, we don't have a humidification at all.
Yeah.
Because it's actually complications are more with the dry gas in NIV. That was a real trouble for us.
Yes.
Because whether you call COVID patients or non-COVID patients, NIV patients, we don't have even though previously we used to have humidifiers properly, nowadays everybody converted HMV. So that is where we are actually facing more problematic nowadays.
Right. Right. I think we are coming close to the end of the session. Another 5 minutes as per the schedule. Any more questions? I think there are not many. I think we answered most of the questions in the chat box.
And so can we put a nasal airway if patient having any airway obstruction like tongue fall? Can you put nasal airway and put the Hfno?
Sir,
I have never used it. I can't say.
Because the cannula itself is small and it is sufficient to go, because the only thing what we are looking at here is that the tongue fall will be there when the patient is GCS, because the indication, if you say that the GCS is less than 12 or other, better not to go for Hfno, because if the GCS is going down, those patients are not for Hfno, because even though after giving anesthesia, particularly at anesthesia cases at the time of intubation for shorter time, it's okay. But longer time, you cannot use Hfno because the tongue fall is there, as I said. Then at that time, whether you use when you're already having this, you're putting in the nasal. Why do you need a nasal airway? Actually, you need an oral pharyngeal airway to prevent the tongue fall.
Yeah, low GCS is always a contraindication, isn't it, for non-invasive ventilation? Yes. Right. Okay. Any more contributions?
What I can say is that not only contribution. I just say that as Padmaja Madam is telling that airway obstruction should be a contraindication. Yes, it is, no doubt about it. The issue is that here, previously out of this picture, I just say, when we got introduction of Clexane, we started saying that it is non-inferior to heparin. But nowadays we use only Clexane. How many of us are using heparin? So this also we say HFN is non-inferior to NIV. But later on, how many indications is going to increase? Let us wait and see. Thank you.
Right. So, sir.
So again, if we talk about the airway obstruction and the comatose patient, I would say it is not an absolute contraindication. Again, it becomes a relative thing. So airway obstruction many times depends on why this airway obstruction is happening. If there is an airway obstruction because of the bronchospasm or something, then it might help with the Hfnc. Once the spasm is relieved, then patient is better, because this moist air is going, moist air and high oxygen content is going. So it may reduce the noxious stimuli, the bronchus, and there could be chances of bronchodilation or at least smoothing of the airway. So that is one aspect. And if all airway obstruction is there, like in laryngeal spasm, like in some laryngeal tumor, I have used Hfnc in few patients because, and those patient intubation risk was quite high. And that, but I feel that certainly can work. So there is nothing like absolute contraindication. But again, where the airway obstruction is there, or patient is comatose, we feel patient cannot maintain its airway reflexes, use Hfnc like NIV is again relative indication, and we have to decide in case to case basis and time to time. Like
if you look at the, I think sir's disconnection, I don't know. Maybe if you look at that Thrive study, yeah. Deepak Goyal is back, yeah.
Yeah, sorry. So it was reconnected. Like in a comatose patient, if it
The place. Any chances. So rather than anything, HFN was much beneficial. Coming to the justification of both the together, what they have been studied actually saying that if you see one paper in between, I mentioned that it's like a teamwork or working. They have studied saying that using HFNO and in between 4 to 6 hours, 2 hours instead of oxygen therapy and used HFNO. So the combination of NIV and HFNO was much better than the combination of NIV and conventional oxygen therapy. It is studied.
There is one question, Achyut.
Yeah. One question on YouTube apparently. Is there a role of Hfnc in patients with tracheostomy tube on?
Yes, definitely. As Dr. Mohan has already highlighted the use of NIV intermittently and HFNOV intermittently, the same thing can be extrapolated to CPAP intermittently and HFNOV intermittently. We have done in many patients. In COVID, there were certain patients who took at least 2 months to wean from ventilator totally. And we did it with the help of HFNOV. And it was very easy to maintain. So what we did, we gradually bring them to control. From control mode, we intermittently give them to pressure support, gradually increase the time of pressure support, then gradually decrease the pressure support, and then we gradually make them like intermittently with CPAP and pressure support, and intermittently with the HFNOV. And gradually we increase the duration of HNFOV and wean them on this.
Dr. Govil, about the role of HFNO in tracheostomy?
No, I'm talking about the tracheostomy only, boss.
Right.
So patient who was ventilated for 2 months, already tracheostomy was done.
Right.
And we were facing difficulty in weaning. So what we did, we on the tracheostomy we made CPAP, and from CPAP and pressure support, we gradually intermittently we put on the HFNOV and gradually wean.
Right.
And the beauty of HFNOV, they can be shifted to HDU also on HFNOV.
Okay.
As we are talking about Achyut, anyway, we are actually trying to remove the carbon dioxide. We are reduce the dead space. The same thing, tracheostomy, we are going to reduce the dead space. We are reducing the anatomical, so that the work of breathing is reduced. At the same time, we are helping with this Hfno so that humidification is proper and improving, and weaning is maybe slower, particularly for more lung is involved, and it takes time, as you said rightly, sir.
Yes, connecting the tubing, the tubing part, the nasal cannulae, do they go into the tracheostomy tube?
No. There is a separate attachment.
Okay.
So it is like a open T-piece with a hood.
Okay.
So there is a T-piece, like L-shaped piece with a hood. So from hood the expiration takes place. So hood is just partially covering.
Right, sir. Okay.
Like you must remember the photo of Sheshnag at the head of the Bhagwan Vishnu. So it is like this. The hood is covering the opening of the the tracheostomy tube.
Right. Okay.
But little doubtful. Sheshnag is open and the Vishnu or Shiva?
Right. Okay. If there are not many questions left to be answered, shall we close the scientific session or discussion?
Yeah. Thank you,
Dr. Sir.
Thank you, sir. Thank you, Mohan sir, for excellent presentation, and thank you, Deepak Govil sir, for clearing all the doubts from the audience and myself and all audience. And thank you both of you, and very nice and excellent presentation. Now I request Dr. Vijita to end the session by vote of thanks. Thank you, sir.
Before that,
Thank you
I just want to thank the audience. Dr. Kuchel Babu is there in the audience. Dr. Padmaja Durga is there in the audience. Dr. Vishnu Mahesh Babu is there in the audience. I thank all of you, the seniors and teachers, for being a part of this academic session. And if there is anything to share, kindly, Dr. Kuchel Babu, Dr. Mahesh Babu, and Dr. Padmaja Durga, madam, do you have anything to share? Please come forward, sir. I don't know whether that option is there, or at least...
They come on the video live?
Sir, they can't come on the video.
Okay.
Only they can just have... they can write it down if they want.
Okay.
Yeah. So I thank all of you. I thank Dr. Deepak Govil sir for being the expert panelist and moderator for this program. And I thank Dr. Mohan Maharaj for delivering the lecture on non-COVID usage of Hfno. And I thank Fisher and Paykel company for supporting this program. And I thank Dr. Vijita for doing the technical part. And I request Dr. Vijita to say a few words.
Yes, sir.
Yeah, please.
Yeah. So thank you very much for participating in this webinar. And we can just thank Fisher and Paykel for their support. And Dr. Mohan Maharaj as a speaker, as always, he has extended his support. And Dr. Deepak Govil. And also the Dr. John and Dr. Achut as representing ISCCM VIzag. So we thank each and everyone for this wonderful session, and we like to have feedbacks from the participants. So we will send them some link, and they can send their feedbacks through the link.
Yeah.
So that is it. Thank you very much, everyone.
Yeah.
Thank you, sir.
Thank you very much.
Thank you very much.
Thank you very much for all of you.
Thank you.
Thank you.
Thank you.